everyone. Welcome to this session of CSI TV. I'm Dr. Karthikeyan. I'm Professor of Cardiology at All India Institute of Medical Sciences. And this is Professor P.P. Mohanan. He's from Westport Hospital in Thrissur. And he's a senior cardiologist who's done a lot of work on ACS in Kerala. So we will be talking to him about the Kerala ACS Registry in particular and some other aspects of the ACS scene in India and how we can scale up what they've done in Kerala to the rest of the country. So,
thank you, Professor Karthikeyan, for this opportunity. Kerala ACS Registry is the largest ACS registry from India. And as we are aware, despite the grim statistics of cardiovascular disease in our country, we have very poor scientific research output. And that was one of the innovations that the Cardiological Society of India Kerala chapter has done, where we collaborated with about 125 hospitals in Kerala and brought out a registry of 25,753 patients with acute coronary syndrome. And what we saw also surprised us a little bit in the sense that now we have a high STEMI mortality. The STEMI mortality was something to the tune of 8.4%, which is definitely higher than whatever is prevalent in the other part of the country. And this may be attributable to one, of course, the delayed arrival of the patient with ACS, and then the paucity of the reperfusion, the timely reperfusion, and maybe some inappropriate therapy also. And possibly the most important thing was the underusage of guideline-directed medical treatment. So that made us learn quite a number of lessons, how to counter them, and how to sort of get over these inadequacies in the management of acute coronary syndrome.
I wanted to particularly ask you about the one you mentioned that inappropriate therapies. For example, we have this a bunch of people with ACS, NSTE ACS who received thrombolytic therapy. So why do you think that happened? What was the...
I mean, basically, people have a notion because you should know that out of the 125 hospitals, about 45 to 48% were managed by physicians. I'm not saying that is the root cause, but people have a notion that, well, whenever you have a thrombotic milieu, antithrombotic drugs or lytic drugs may be useful, but that may be one of the reasons that the physicians are also not really into the guideline-based therapy. So, which we could correct. We could, just like in the West, where they have shown that adherence to the guideline-based therapy through various methods, various trials, they have shown that if you improve by educating the physicians, by educating the paramedics, we can improve the results.
The other interesting thing about the Kerala ACS registry was that your time for STEMI, your time to reperfusion was about 5 hours, was it? So you've also published the access to reperfusion therapies in a separate paper. So I noticed that you said most patients in Kerala live within half an hour of a primary PCI lab. So why do you think there is this discrepancy?
Well, there is one definite reason in the sense. When we did the Kerala ACS registry, that was in 2007, 2009. The number of cath labs at that time was 26, while when we published the ACS registry, the rural, the setting of the park registry, the primary angioplasty registry, that was in 2016. And when we have 106 cath labs. Okay. So the number of cath labs have significantly improved and possibly that is the one single reason. And of the lessons learned from the Kerala ACS registry also, I am sure, should have kept in their mind, because our rate of reperfusion, the lytic rate was 45% and the primary PCI was a meager 12%. While if you look at the Kerala, the ACS QUIC, the quality improvement data, reperfusion is 60 plus. So there's a tremendous improvement in the reperfusion strategy that is happening.
And what's the primary PCI rate in the quality improvement?
The quality improvement we have touched on to 50%.
50%. that is excellent. So I think Kerala ACS group needs to be congratulated on what you've done, a pioneering bit of study in this country. I don't think anybody else, any other state, any other CSI, state CSI has managed to do this. So I wanted to ask you, what is it that makes the Kerala group special, so that we can learn from the Kerala group?
We always pride ourselves about the Kerala model. Now you would have heard about the Kerala model of the economic persistence and the surveillance. Same way, I think there is a Kerala model of cardiovascular research where the funding is taken care of by the Cardiological Society. So the investigators need not worry about how do I get the funding for this method. And the second part, there are some devoted groups of people, and mind you, they are not very much trained in any cardiovascular research. Now, I myself is not have a front like you. I didn't undergo any formal training. But then we have been involved in some of these clinical trials and multinational trials, and we wanted to do some legitimate research, because one of the things that we always say is, Indian research is of poor quality. We wanted to have a high quality research with meager reserves. So this, I will say, is a Kerala model where the funding is done by the one institution, your own maybe mother body, fine, if you can do that, fine. Then there are about groups of people, a state coordinator. For example, in Kerala ACS Registry and in ACS Group, I was fortunate to be the coordinator. Then we have other collaborators. Each one of the cardiologists in Kerala now wanted to be part of the research program, and they have no hesitation to share their data.
So the other interesting thing, I realized that one of the most important things that is needed for doing research is an incentive for doing research. I mean, academic investigators, like in hospitals like ours, we have an academic incentive, so that is a given. But what about, so the large majority of your group are people who do private practice. So what is the incentive? What is it that drives you?
I think the once we started the Kerala ACS Registry, and that sort of percolated an intense desire among our junior colleagues to be part of some scientific research program. And mind you, we did never pay any of the investigators any substantial sum. Whatever very meager sum that we paid was mainly used to continue the research activity. So I think it is the desire to be part of a research program which will be useful for our patients. And also, that started. Now we have 7 registries running in Kerala. A primary PCI registry, a pulmonary hypertension registry, an atrial fibrillation registry, a vitamin K polymorphism registry. You name it, we are running it.
That's amazing. So before we close, I just wanted to get your insights on what do you think are the most important steps you must have seen in the ACS QUIP, which is a follow-up to your ACS registry. What is it that is needed to make at least the state of Kerala comparable to the West, say at least Europe, Western Europe, in terms of access to reperfusion therapies for STEMI? What are the few things that you think are important?
I mean, very, very important issue that you have brought in, because the systems of care especially the STEMI care in our country is very meager. The systems of care should be there, that's for sure. But then the contribution of a cardiologist is, I will not say is minimal, but is limited. So the second part, that is one part. The second part will be how to improve the adherence to the drugs that he should be getting. Every patient with ACS should be getting a list of drugs. So an admission, discharge checklist, and audit feedback. Now that was one of our success stories. We gave all these hospitals every monthly an audit feedback report saying that this is the way that I am treating, this is my dual antiplatelet, this is my rate of primary PCI or my reperfusion rate. So, and also the other patient education material, all these matters. The systems of care is something which definitely merits
scope of. But if I were to ask you only about improving access to reperfusion, you may not comment if you don't want to, but in adjacent Tamil Nadu, there is a push for doing pharmacoinvasive therapy. So what do you think about that? Is that a model which is scalable to the country, or?
Well, I'm not very certain. But if you ask me about Kerala, I mean, Kerala possibly may not be the best state to implement the pharmacoinvasive therapy, because already we have 126, and the areas where fibrinolytic therapy used, I will not say that it is irrelevant, but it is still relevant, but it is it may be relevant in certain situations, certain states where now the cath lab numbers, the sheer presence of a cath lab doesn't warranty the proper reperfusion. We have seen, even despite all these cath labs coming here, your balloon time may be still 4 hours, 3 hours. So what is the fun in that? So I will not say pharmacoinvasive therapy is suitable to every state in Kerala. I mean, every state in India. It may be, it has its relevance. I'm not negating that.
One question about the number of you said more than 100 cath labs in Kerala, small state, so high density of cath labs. So how many of these are private cath labs and how many of them are public cath labs?
I mean, now the government sector has tremendously improved. Earlier it was something like 2080. Now it's about 35, 65 or something. But you again makes another important issues. The mere presence of cath lab doesn't guarantee a 24/7 primary PCI service. Many of them has their limitations.
Plus also reimbursement issues. A lot of it might be out of pocket and patients might not want to.
Absolutely.
Is there also, I know that in some parts of India, patients who are sick, like STEMI patients are often, they are not treated with primary PCI because of the risk of, say, untoward events during the procedure, and then there is a backlash against the hospital. So that happens quite often in many parts of the country. So is that a deterrent to providing?
I mean, I will not say that will act as a deterrent, but then in a situation where a country like India, where even the healthcare delivery system is not properly instituted or maintained, we have to be careful in saying that, well, this system is the only one which is suitable for us. But as you rightly said, the primary PCI, all of us know, is the main thing which will save STEMI patients. There is definitely every state should try to implement as much as possibly that particular program. There is a role for pharmacoinvasive. Our bane will be the delayed presentation where we can only request the government and the policymakers to do something about that.
So finally, I'll try to ask you something which is probably in the realm of policy, but maybe you can, if you were asked by the policy apparatus in this country about what are the things that can be done to improve primary access to STEMI care in this country, for the country as a whole. So what do you think should be our primary aim of focus?
I mean, our primary education, our primary policy should be educate our people. That is number one, because in a nation obsessed with, I will say, quote unquote, gas, every patient who has a chest discomfort has to realize that this could be a myocardial infarction and they have to reach a physician. I think that's the most important thing. All our developments in implementing the systems of care will be of waste if we don't educate our patients and tell them that this is the most important thing. I think that will come as the number one point, apart from implementing the systems of care and implementing a quality improvement program.
And one final question I have to ask you, because you see, we are a large country, very educated medical professionals, but unfortunately our research output is not up to scratch. But you have made it happen in Kerala. So what would your advice be to the rest of the country, I mean other states, in order to be able to produce this kind of data? We have lots of potential, but we've never lived up to it. So what would your advice be?
Learning from whatever little things, I will say we're not a great thing, but we have done something, and that is only because of the collaborative efforts of the people, of the cardiologists and physicians in Kerala. Every state possibly can emulate. If Kerala can do it, any other state can do it. What it requires is some certain leadership qualities of cardiologists who will try to collaborate with the youngsters and others who are very keen to involve in any research programs. And we don't pay them, we don't even involve them, mention them in the paper that we have released, but they are part of us. I think a collaborative effort of the cardiological group in our country will see that our research outputs improves substantially.
Thank you, Dr. Mohanan. That was very good
Thank you.
talking to you, and I hope this will provide some incentive for people in the rest of the country to emulate what you've done, so that we can really produce good data to direct care.
Thank you very much. Thank you.
Thank you very much.